You're listening to Boomers Today with your host, Frank Sampson.
Well, welcome to Boomers Today. I'm your host, Frank Sampson, and of course, each week we bring you important and very useful information on issues facing baby boomers, their parents, and other loved ones. And as I do on every show, I thank all of you. And I thank all of you because our listeners are growing each and every day organically, because you're telling friends and family and business associates about our podcasts, our show, or individual podcasts. And I know why you're doing it. You're doing it because we have great guests, and I'm not going to disappoint you today. We have with us Monique Nugent, who's MD and is a practicing hospitalist and physician leader. She completed her medical school and residency training at Loma School of Medicine and her MPH from Harvard T.H. School of Public Health. Nugent has built her medical career around hospital-based care to include leadership and advocacy work, advocating for every patient by working to make healthcare equitable, safe, and high quality. She has also written the book, Prescription for Admission, a doctor's guide for navigating the hospital, advocating for yourself, and having a better hospitalization. So may I call you Monique or Dr. Nugent? Both? Either?
Monique is fine. Thank you so much for having me.
Yeah, Monique, is a pleasure having you. Yes. I thought maybe we would start out. Certainly, we're going to have some time to talk a little bit more about your book, which I think people will be very interested in. But I'm going to just start out with just a very basic question. Certainly, many of us in the industry know the answer, but there's a lot of people may have heard the term but don't quite understand what it is. But a hospitalist. Tell us a little bit more exactly what that means.
Yes. So I am a hospitalist, which means that I am an internist who practices only in the hospital. I only see acutely hospitalized patients, but I don't see patients in the ICU or the critical care unit. Those are intensivists. So you come to the hospital and in the emergency department, they say you're too sick to leave, but you don't need the ICU. Then you would be cared for by myself or one of my colleagues, which is a hospitalist. And this way of practicing really acknowledges that the things that go on inside a hospital, both the acute medical presentation of chronic illnesses or new illnesses and injuries, but also the way that the medicine is practiced, the social supports that are necessary, are very unique. It's a really unique time in a person's journey of medical care. And so really focusing on just being present only in the hospital. There's a great body of research about the work that goes on in hospitals, the way that hospitalist practice has spread out past internal medicine into pediatrics. So you'll find pediatric hospitalists. You'll find obstetricians who only work in the hospital. They're called laborists. Acute care surgeons, who are surgeons who see everything that come into the emergency department and the things that are happening on the floor. Again, recognizing that these are acute needs and really special, and how we practice and the teams that support that practice do require special attention.
So does the patient know before being admitted of the information about the hospitalist, or is it usually they introduced to that option once they're in the hospital? How does that work?
Yeah, so this type of practice grew out of kind of the limitations of the old way of seeing patients in the hospital. Back in the 70s, 80s, early 90s, what you would find is that physicians, primary care doctors would jump between their clinic and the hospital, right? And it becomes a little bit inefficient and unsafe when you think about nurses who need something from the physician immediately, patients who are undergoing illnesses or having emergencies within the hospital. And so what happened was a group of enterprising physicians, young physicians, got together and they said, hey, we'll see your patients in the hospital, you see the patients in the clinic, and we'll have a financially beneficial model for the two of us. And so hospitals have also seen that this is a beneficial model for them themselves to practice. I don't know of a lot of primary care doctors who do both anymore, seeing their own patients in the hospital and also in clinic. So I'm going to put your money on, and my money on, the fact that if you show up in a hospital, you're likely to be cared for by a hospitalist, right? This has become kind of the accepted type of practice that we're seeing throughout hospitals for lots of reasons: safety reasons, process reasons, financial reasons. I know that particularly for my older patients say that, well, I want to see my doctor. I'm really much more comfortable with that. If your physician has practicing capabilities in the hospital, that's great if they have that set up, but it's just not something that we're seeing happen more and more. And so I would tell your listeners that if you come to a hospital, unless you know specifically that you'll be cared for by your primary care physician, expect to be cared for by the team that's based in the hospital, which is going to include a hospitalist of some sort or an intensivist if you need the ICU. The on-call team, right? So a lot of people say, I want to see my cardiologist, and their cardiologist may not be available at that time, but one of their partners who is in the hospital would be on call. And so making sure that we can wrap our services around our patients and working as a team really is important in the hospital. So I'd likely say that your listeners are likely to encounter a hospitalist if they are admitted.
Do they know it's a hospitalist, or they just think it's an employee for the hospital that's just doing their job? I mean, how do they know they're a hospitalist?
Your physician should introduce themselves, or your provider should introduce themselves and the role that they're going to play in your care. The employment model of physicians varies state by state, right? So some states say that physicians cannot be employed by the hospital. Others states will allow that to happen. You have really famous hospital groups such as Kaiser Permanente, right? It is the Permanente group, I believe, that works for Kaiser.
I'm pretty familiar with them being based in California. Yeah.
Right. So, but the group itself is not owned by Kaiser, right? They are a group of providers who have an exclusive contract, because in California they cannot be employed by the hospital, right? So you should always ask any provider who comes in who they are and what role they're playing in your care. Because it does get complicated, and that's something I talk about in my book. Like, write down names and roles, take cards, know who's who. Because in addition to meeting a hospitalist, right, then you might find a specialist that you need to see. So you may meet a neurologist who may be brand new to you. Then you're going to start meeting physical therapists, and then you're going to start meeting social workers. So ask who this person is and what their role in your care is.
Got it. So what recommendations do you have to our listeners who either themselves or they have a loved one that's going to be going into the hospital? So talk to us about how they should prepare for that hospital stay from your perspective.
Two things that I always say. One, knowledge of safety when it comes to a hospital. So the more that you know about yourself and the more that the hospital you will be cared in or cared for in knows about you, is the more that they can build your story and create a safe medical plan. So what does that mean? It's really important for people to know some of their medical history and know their medications. I really do drive home the medications as important, because when you come into a hospital, it may not be safe for you to continue taking the medicines that you always took at home, or it may be vital for you to continue those medications, right? And those decisions can't be made if the care team doesn't know what medicines you're taking. And I know that medicine names can be complicated. So it's not about knowing them, at least know where to get that information, right? So if you have an app for your primary care doctor or your pharmacy, if you write them down and keep them in your wallet, it's important because it's going to ensure that the care plan can be made in a safe manner.
Great.
The second thing that I talk about is open and honest conversations before you end up in a hospital for any reason. I know it's not a pleasant idea that any of us would be hospitalized, but most of us will come into contact with a hospital at some point in our life. And if you can have open and honest conversations with your healthcare providers beforehand and your friends and family about the supports that you need, your wishes, your fears, your hopes, your desires, your capabilities at home, what your long-term goals are, then you are setting people up to be able to support you, because you should not attempt, and I always really try to tell people this, have a care partner. Try not to be in a hospital alone. Hospitalizations are isolating, but things move so quickly, things change so often that you do need another set of eyes and ears. You need another mouthpiece to help advocate for you and help you bring all the things together. And so if you have someone, a spouse, a significant other, an adult child, a neighbor, someone from your church who supports you in your health journey, keep having these open, honest conversations with them so that if you become hospitalized, they know how to show up for you. And if something should happen and you're not able to speak for yourself, then they understand what your values are, what your goals are, what your wishes are, right? The third thing that I say, and this really comes off of what I just talked about, is completing some documents to speak for you if you can't speak for yourself. And so when you don't need to have emergent conversations is when you should have these conversations, right? Or vital conversations. Take time to sit down and complete an advance directive. So an advance directive is a legal document that states all sorts of things about what you would want done for your care in the instance that you can't speak for yourself. And this will include and should include who you would list as that decision maker, your healthcare proxy. And then you can put anything else afterwards. I've seen advance directives that are very, very curt and says, like, my daughter Susie will be my healthcare proxy, and that's it. And I've seen advance directives that were extremely well laid out, stating, limitations of care and time, things that they would try and they wouldn't try, who would be the first versus the second healthcare proxy if that first person isn't available. Take the time and complete these documents and make sure that the people who you're listing as your healthcare proxy agree to this and aware of your wishes. You've had these uncomfortable but necessary conversations. And then distribute that document to your primary care physician. If you're seeing a specialist, your specialist, whoever needs to have that document within their medical record. A second piece of document is called a MOLST or a POST form, a portable order of life-sustaining treatment or a mobile order of life-sustaining treatment. I trained in California, we called it a POST. Here in Massachusetts, we call it a MOLST form. And what this does, it says, yes or no, I wouldn't want chest compressions. Yes or no, I wouldn't want to be intubated. What would I be willing to accept for artificial nutrition and hydration? This is different from your advance directive in that the advance directive is a legal document. The MOLST or the POLST is a medical form. It's a medical order. It is the only medical order that I know that patients can write, right? Every other medical order, it requires a provider to write this. But you're going to sit down with your primary care doctor, you're going to fill out this form to the best of your abilities and your comfort. They will sign it, you will sign it, and you will have them put it into their medical record, right? And this is a document that's going to serve as your own voice in case you can't speak for yourself if you come into the hospital, right? And one is medical, MOLST, one is legal, POLST, right? One is medical, MOLST or POLST, the other one is legal, and that's advanced directive. And these two documents will serve to protect you and give your voice when you can't speak for yourself. And that's why I say also have these conversations with your loved ones. Somebody once said to me that I consider it a gift that I'm giving to them. And I really took that to heart because it is. If you can give somebody your voice and allow them to feel that they're honoring you rather than making decisions for you if needed, right? They're doing the thing you would want. That relieves people of a lot of feelings of guilt, of responsibility, or turmoil. What it does instead is says, I know this is what they want, I'm honoring them, and it can make people really feel as if they're giving you a good, loving act. So the three things: one, know some information about yourself, particularly your medication. The second one, build your community and have open, honest conversations with them about your values, your hopes, your goals, your limitations. And the third is to complete the documents to support you should you come into the hospital and not be able to speak for yourself. An advanced directive and a MOLST or POLST form. And that terminology differs on your state.
Got it. No, and actually those forms usually, depending on the state, come in some bright color, right?
Bright pink, yeah.
Bright pink, yeah, no, because even if you're not going in the hospital, obviously somebody who's elderly and has issues, and they it literally is supposed to post it nearby you. So if you had to call 911 and emergency came out, they at least know your wishes in a emergency situation. So yeah, no, that's great recommendation. So this is great preparation before the hospital. Now you're in the hospital, and they're going to start running some tests, and they're going to set up some procedures for you and things like that. I mean, what advice do you have there? I mean, usually I think most hospitals today may explain why they're having these tests or procedures. What suggestion do you have there?
So I break down hospital stays in kind of three phases. The average stay in the hospital in this country is about 5 days. Some people will be in and out quickly. Some people have protracted hospital stays, right? But in those 5 days, you're going to have something called the testing phase. And again, this is Dr. Nugent's, Monique's own terminology. So if you walk around asking if you're in the testing phase, they may not understand, right? But what you just talked about, that tends to be in the beginning of a hospital stay, where lots of things are happening. Information gathering is going on. You're getting MRIs or CAT scans, you're meeting cardiologists, you're getting blood work. All of that is to get information to further make a good plan for you, right? Any test that you have that is invasive, meaning someone's going to poke a hole in you, cut on you, that's going to require something called an informed consent. And that is a document that the person who's doing the test or their team should be signing with you. And they're going to say, look, this is the test that we're going to do, or the procedure we're going to do. These are the risks associated with it. These are the alternatives. And these are the benefits of getting this. And this is your chance to ask all of the questions. Now, some of it, may sound boilerplate. Anytime you have a surgery, someone's going to say there's going to be a risk of pain, infection, bleeding, right? Those things we understand. But you may have really much more specific questions about your pain. How is my pain going to be managed during the procedure? Is this general anesthesia or is this local anesthesia, right? This is your time to ask all of those questions. And you should, at the end, be informed, as what the document says, an informed consent. And they're going to sign it, you're going to sign it, a witness is going to sign it. Consider it a permission slip. You are giving your permission, or your healthcare agent is giving permission for you to have this invasive procedure done. Other tests not everything gets an informed consent. So your morning daily blood work, that's not going to be an informed consent. X-rays, CAT scans, MRIs, those are not going to be informed consent. But you should be asking the questions. Why are we getting this MRI? And I always encourage people that if it's not to give a vital piece of information or to change the plan, then the next question is, do we need this and what are alternatives, right? If you are feeling not comfortable with getting the procedure. I totally understand. I myself have done it. I get up in the morning, I come into the hospital, I see a critical value for a patient, and I put in a bunch of blood work and lab and stuff, and patients may have things happening to them before I get to the bedside to understand and explain to them what's happening. That's not the best form, and I apologize for when those things do occur. But make sure you're asking, hey, what did that blood work happen to say? What are we doing now that we have this MRI? Does it change what we have to do? Does it mean I need surgery or not need surgery? Things like that, right? And now there is a portal or an app. A lot of the times patients and their family members have the results well before I do or I get into the room. And, you know, people are ready with their questions. And that's the way it should be. It should always be a conversation, a participation back and forth with you and the team to build a plan that's not only medically appropriate and safe, but it goes along with your values and the things that you want to achieve and can achieve.
So Monique, we're going to just take a real quick break, I promise, just to recognize our sponsor. And when we come back, I want to learn a little bit more about your book, and then we'll talk about what happens after, you know, at discharge time. We'll talk about that as well. So do you know anyone who may be concerned about an older driver? Well, Senior Care Authority's Beyond Driving with Dignity program is a facilitated self-assessment program for older drivers. This program has been designed to serve as a vital tool to facilitate older drivers and their families as they make appropriate decisions regarding the future of one's safe driving career. If the individual is a safe driver, an advisor will provide him or her with strategies on how to remain a safe driver as they progress through the aging process. If driving retirement is the appropriate decision, then the individual and their family are offered possible alternatives, resources, and a specific plan to ensure a smooth and successful transition from the driver's seat to the passenger seat. So to learn more, go to www.beyonddrivingwithdignity.com or call 877-907-8841 to connect with a Senior Care Authority advisor in your area. And we're now back with Dr. Monique Nugent, who's a practicing hospitalist, learning a whole lot more about that. So, and also you've written a book called Prescription for Admission, a doctor's guide for navigating the hospital, advocating for yourself, and having a better hospitalization. Kind of self-explanatory what the book is about, I think, but maybe you could shed some additional light on it and who you're targeting and how people can to get your book.
Thank you. So this is a culmination of like years and years of being in totally different types of hospitals on both coasts, East Coast, West Coast, VA hospitals, private hospitals, academic centers. And I just see the same frustrations in family members and patients over and over and over again. And during COVID, I thought, hey, this is a great time to put pen to paper because it was a really unique time for hospitalists in that we didn't have access to friends and family members for patients like we normally do because visiting was limited, extremely limited. And communication became even more fraught. But when I sat down to write it, what I found was that COVID had not actually made any new communication problems. It just exacerbated the ones that existed. And so I sat down to really explain the hospital, who's who, what's what, how to improve your conversations with people, how to think about things the next step ahead. Why are certain things happening? So one of the things I hear all the time from patients is about food. Oh, I'm not allowed to eat this morning. just because I'm having a test or just because I'm having surgery in the afternoon, why is that such a big safety issue? And then to also talk about what happens afterwards, because, you know, ending a hospital stay rarely makes things easier for people, right? Even people who come into the hospital excited, like pregnant people do, they come in, they're excited. They leave with a bundle of joy that just makes things a little bit more complicated, right? And that's kind of the same thing with anyone else who comes in the hospital. Came in for an ache and pain, you may leave with a new diagnosis. You came in because you have a certain issue, but now you need a little bit more support. And so what happens after? You know, what is a nursing home? What are visiting nurses services? You know, what do I do at home to be successful and not come back to the hospital? And I really want to make it user-friendly. So it's got places for people to write in. I'm really hoping people can hear my friendly voice through their reading. I'm really happy that a friend of mine who's a psychiatrist focused on psychosomatic medicine took some time to contribute mental health tips to the book as well. And it's just really meant to be a manual, a user's guide for the hospital.
That's fantastic. Well, congratulations on that. And how can people get your book?
Well, anywhere you buy books. You can find it on Amazon.com, BarnesandNobles.com. It comes in a Kindle version. And please, I really want people to get it. I mean, when I wrote it, I thought, well, everyone's going to be excited to get their hands on this book. And what I found is that though I like talking about hospitals, nobody else likes talking about hospitals. They're not very exciting place to be. And I find that people often find the book after they've had a hospital stay, and they're wondering how they can improve their experience if they have to go back. Another group of people who I think would really benefit from this are people who help take care of either a medically frail family member or an elder in their life, because those are the people who may come into the hospital, and you want to protect them, and you want to advocate for them, and you want to help make their transition out of the hospital as successful as possible.
Great. So we're pretty much out of time, unfortunately, but I want to take just a couple minutes. I know that I mentioned to you that our company, our sponsor, Senior Care Authority, we work with hospitals all over the country and helping families if maybe home isn't the best choice initially. We work with assisted living and of course nursing, etc. But let's talk about that. Let's talk about discharge and what families should be thinking about, that, you know, if they're going to be going home or if they're not, they can't go home because of the situation, options out there. Why don't you talk a little bit about that just in the next couple minutes? Okay.
Yeah, so the person who's going to be your key point person for discharge planning is your case manager. Some hospitals may call them case workers. And this is a nurse who does the coordination of your care after you leave the hospital. And why is it important that this person has like a nursing background? Well, they know what you need, right? They understand how complicated it is to get IV antibiotics into a person. They may understand the intricacies of insulin, and, you know, if a person can do insulin, how often as they need to. And you really want to touch base with this person, I say, when you get admitted. Start discharge planning on admission. And I understand that thought process may be a little off-putting to people. Oh, I just showed up, you're trying to get rid of me. That's not the case at all. It's about making sure that we know what you need to be successful when you leave the hospital. Because like you said, home may not be the right place. Everybody wants to go home. And if you have the support of friends and family, if you have the things you need to be in your home safely, and safety is the big key word, right? Then if home is the right place, then that's great. But for a lot of people, they may not be strong enough to be home. They may have a little bit more care that they need to do, a wound that needs to be cared for, new medications that they need to continue taking. They may not just be safe at home. And so talking to your case manager and finding a place that fits your insurance, your medical needs, and then also your social needs. Is it a place your family and friends can easily get to? Is it a place that you have had a good experience with in the past versus a place you've had a bad experience with in the past, right? Have these open, honest conversations. This is the person who you should just lay it all on the line and say, hey, this is what we've got. This is what we need. Where can you support us? And help them to help you find a place that's going to be a good fit.
Great advice. Great advice. Dr. Monique Nugent, thank you so much for joining us. Check out her book, Prescription for Admission. Thank you so much for joining us. I really appreciate it. And thank you, everybody, for joining us on Boomers Today. Please be safe. We'll talk to everybody next week.
You've been listening to Boomers Today with Frank Sampson. To learn more about today's show, visit boomerstodayradio.com and join us next time for another edition of Boomers Today.